Good morning, colleagues, and thank you very much to the organizers for inviting me to deliver this presentation at your 2021 meeting. I really wish I could be there with you in person. I've been asked to speak about a GFR equation for Africa, and as you see, I've added a little question mark at the end there. Now, all of us have seen estimates like this. This is from Kitty Yaga and colleagues in Kidney International, where they state that more than 850 million people across the world have some form of kidney disease. That's about 1 adult in 10. Now, when we use such estimates to describe the burden of disease, the tools we use to make the diagnosis are, of course, extremely important. This is our diagnosis, our diagnostic criteria. CKD is there when we see kidney damage for more than 3 months, where it has implications for health. And one of the most important aspects we look at is a decrease in kidney function. The GFR, the glomerular filtration rate, is regarded as the best overall parameter of kidney function. These are 2 articles from Cape Town. The first one was one we did in Teachers, a population prevalence study of CKD, and we reported a prevalence of 6.1% using the CKD EPI equation. Had we used the Mdrd equation, that prevalence would have been 10%. The paper below is also from Cape Town in the geographical cohort, and there the authors found a prevalence of 17.3% using the CKD EPI equation. Once again, the Mdrd would have given higher estimates, in this case over 20%. So as you see, it's critically important that the tools we use to diagnose kidney disease are as accurate as possible. Now, GFR can be directly measured using the clearance of endogenous or exogenous markers from plasma. And we normally report it as moles per minute per 1.73 meters squared to correct for body size. And the endogenous markers we commonly use are creatinine and sometimes cystatin C. The exogenous markers are inulin, the gold standard, and then a variety of isotopes and also non-isotopic markers. Inulin is the gold standard. It's a plant polysaccharide, a perfect marker in that it is transported in plasma, not protein-bound, freely filtered at the glomerulus, not secreted by the tubules, not metabolized or reabsorbed, but it is not easy to do. It's more of a research or experimental tool. It needs a continuous IV infusion and the taking of multiple blood and urine samples. Here is a table that compares a few different methods. Inulin, iothalamate, which was used for the CKD EPI equations, and then iohexol. And each method has its pros and cons. So you need to be aware of all the details, all the best operating procedures when measuring GFR. There are factors other than kidney disease which can affect GFR. Pregnancy, protein loading, high blood sugars can all increase the GFR in the absence of any kidney disease. And then on the other hand, contracted ECF volumes will reduce kidney perfusion, non-steroidal use, and the use of ACE inhibitors can also lower the GFR. We've all seen this graphic, which describes the relationship between GFR on the x-axis and serum creatinine on the y-axis. And as GFR falls from the bottom right, we move left, GFR falls. There's initially a slow rise in creatinine, and then this becomes steeper and steeper, and we get this exponential curve. And because of this relationship, people have tried to predict GFR from serum creatinine. Now, these equations include, in the early days, the Cockcroft-Gault equation. Then we had the Mdrd in its various forms. And more recently, we've been using the CKD EPI equation. The assumption in using all of these is that creatinine is a good marker of GFR. You'll note that many of these assumptions are not completely true. We also assume that creatinine production and therefore excretion is related to muscle mass, and that we can predict this by looking at factors such as age and sex. And you'll see in these equations that the factors that we include are those trying to get at the muscle mass or the daily creatinine production. We also assume that creatinine can be accurately measured. This was not always the case, but should be less of a problem nowadays. And finally, we assume that the patient is in steady state. And this is really an important one. We should not be trying to estimate GFR when the creatinine is clearly rising or falling. I always use this analogy of the water tank, where the water level being the creatinine concentration. If the creatinine concentration or the water level is constant, this means that the inflow is exactly equal to the outflow. In other words, that the daily production of creatinine from muscle is exactly balanced by the removal via the kidneys, in other words, the GFR. And if we can know the values of two of these variables, the creatinine concentration, which is easily measured, and the production, which we estimate based on the muscle mass using factors such as age and sex, we can then calculate the third variable, in other words, the GFR. Now, there are factors other than kidney disease which may affect creatinine concentration. Pregnancy, we've mentioned this before. And then in the absence of any change in GFR, creatinine may change because of malnutrition and reduced muscle mass, so less production per day of creatinine. Short term, there may be increases in creatinine because of the ingestion of a protein load. The use of drugs which impair tubular secretion will cause rises in creatinine concentration. And then some drugs and ketoacidosis can interfere with the assay and be measured as creatinine, giving you a falsely elevated concentration. So these days, all laboratories should be reporting what we call standardized creatinine, where their assays are calibrated with IDMS, stands for isotope dilution mass spectrometry, IDMS traceable reference material. And this allows measurements in one lab to be exactly the same as measurements in another. There are two types of assays which are widely used, the Jaffe reaction and the enzymatic method. Both are acceptable, although it should be noted that the Jaffe reaction methods are more susceptible to interference by things such as antibiotics and keto acids and so on. And the article at the bottom is where these recommendations were first made. Now, when a new prediction equation is developed, this usually involves a large study, an expensive project, and this is where these equations are derived. Their performance then, especially their performance in other populations, needs to be evaluated looking at things such as bias. In other words, by how much does the estimated GFR under or overestimate the real GFR? Are the equations giving us precise estimates? In other words, is there much scatter of repeated measurements? What about the accuracy? And you read about the P30 value, which refers to the percentage of estimated GFRs within 30% of measured GFR. And the standard is that we should aim for more than 90%. And then we can also use Bland-Altman difference plots to look at the difference between measured and estimated GFR. Now, when we find differences in our populations, when we apply these equations, it may be that our population is different from that in which the equation was originally developed in terms of the age profile of the patients, the kidney function, the pathology, genetics, yes, and nutrition, and maybe other factors we've not even considered. So let's run through a few of the equations. The Cockcroft-Gault equation was developed in about 250 white males, but obviously since then validated in other populations. It was easy to work out at the bedside, but it has not been adapted for use with standardized creatinine, and it should no longer be used. The Mdrd equation came along in 1999. It was developed during the course of the modification of diet in renal disease study, hence the name, in about 1,600 patients. 2/3 of the patient samples were used to develop the equations and 1/3 to test it. And it's got an excellent correlation with measured GFR. There are various variations of this equation, but the simplified 4-variable equation you see in the blue box is the one that is most commonly used. And you also see down there the ethnicity factor, which was used for African Americans. This is a figure from the original paper by Levy and colleagues, and you see the good correlation between measured GFR on the x-axis and estimated by the equation on the y-axis. But you will note that at higher GFRs, there is more of a scatter. And that is why that when the lab reports the Mdrd equation, if the value is above 60, it simply says greater than 60 and doesn't give you a precise value. 10 years later, the same team gave us the CKD epi equation. It uses the same variables as the Mdrd equation, but is more accurate, especially at higher GFRs. There have been other equations like this one more recently called the full age spectrum equation, the FAS equation, which is a single equation which can be used for children over the age of 2 and for adults. It's not yet widely adopted. So KDIGO tells us that we should not be using time Durant collections any longer. They do not provide better estimates than prediction equations. All laboratories should use standardized assays and report standardized creatinine. The lab should report GFR estimations and not just serum creatinine alone. And we should use the CKD epi equation in adults unless another equation has been proven to be better in your population. In pediatrics, the Schwartz formula is most commonly used. Here you see a table from the paper by Fabian and colleagues comparing some of the African studies which have looked at the performance of eGFR equations and comparing it with measured GFR. I'll run through a few of these. In 2008, I'll start with South African studies. In 2008, Van Deventer and colleagues looked at 100 Black South Africans and found a reasonably good performance of the Mdrd equation without using the ethnicity factor. With the factor, bias was 27% and P30 only 52%. Without the factor, bias dropped to 5% and P30 improved to 74%. Not yet at the 90% level that the guidelines recommend. In KwaZulu-Natal, near Durban, Nomandla Madala and colleagues looked at Indian and Black patients, found once again that accuracy is better without the ethnicity factor. The P30 was only in the 30 to 70% range and especially poor at lower GFRs. And they found that the formulae did not predict GFR well in patients of Indian origin. Also in KwaZulu-Natal, Moodley and colleagues in a slightly larger study found that the accuracy of the equations was better without using the ethnicity factor, and that the CKD epi equation was better than the Mdrd. We did this study in Cape Town in patients of mixed ancestry, finding once again that we should not be using the ethnicity factor. We found P30s of 80% and 73% for CKD epi and for Mdrd, with a slight tendency to overestimate GFR. Here's a paper from Kenya, where 99 HIV-infected patients were studied. They had normal or near normal GFRs, most of them, and they found that the overall accuracy was highest for the CKD epi equation, P30 very close to 90%. Once again, no need to use the ethnicity factor. In West Africa, Bakabau and colleagues, in the largest African study to my knowledge, looked at patients, nearly 500 patients in the DRC and the Ivory Coast, found that both the FAS equation and the CKD epi equation performed well, P30 87%, but not such good performance at lower GFRs. Note that they only had 80 patients, though, with GFRs under 60 moles per minute. They did not find any advantage to using cystatin C, either alone or in combination with creatinine, and Mdrd performed worst of all. Now, this is an interesting article by Jennifer Holness, who looked at how to adapt an existing equation for a specific population, and she did this in children. So they looked at 8 different creatinine-based equations and compared that to measured GFR using chromium-51 EDTA, finding that the existing pediatric equations all performed quite poorly. They then proceeded to use a simple and widely available tool called the Microsoft Excel Solver. This is an Excel add-in, and they used this tool to modify the parameters of the equations and found a substantial improvement in accuracy. Finally, I'd like to show you this paper, which is a study protocol of a very large study by Robert Kalisubula and his colleagues. They aim to include 3,000 adults from Uganda, Malawi, and South Africa, measure GFR in these populations using IXL clearance, and then assess the performance of the various estimating equations. They also then planned to either modify or develop new equations if necessary. I've heard from Robert, it seems that they have completed their study and that the paper reporting this is currently under review. So colleagues, in conclusion, it seems that for now anyway, the eGFR equation for Africa remains the CKD equation, definitely without using the ethnicity factor. We should, wherever possible, test equations on our own populations and modify or develop new equations as needed. Remember the Excel tool in the wholeness paper. That's a simple method we could use to optimize some of these equations. And we keenly await the results of the ARC study, which may throw additional light on this topic. Thank you very much.